All right, we are ready to go ahead. All right, let's start now. Right. So in today's topic, in today's this session, we're going to discuss about the myocardial infarction. We'll briefly discuss about the management, as well as we'll try to cover heart failure and cardiomyopathy. Okay. Yes. So first of all, when we talk about the myocardial infarction, definitely it all begins since 15th century. All right. So there were a lot of misconceptions in the initial phase that it's because of the god's curse or something like that. And it was the first time in 1550, Edward Hyde was the person. Yes, Mohit, any issue? Okay. Please don't. If you have any doubt, just put the question in the chat section. All right. No problem. So, first of all, this Edward Hyde was the person who gave the term of the chest pain and angina to us. And William Haverden then told that angina is nothing but associated with the heart disease. Okay. All right. Then Edward Jenner came and he proposed a good theory that angina occurs because of the coronary insufficiency. All right. So we have a heart like this, isn't it? And we have coronaries, right coronary artery and left coronary artery respectively. We know about the blood supply of that, which we're going to discuss in the coming slides as well. All right. So due to the insufficiency of the coronary arteries, can anybody tell me quickly when do coronary arteries basically supply the blood to the heart? In which phase? Systole or diastole? Yes, very good. Easy one. All right. So William Osler then came and told that it's associated with the cramp of the heart muscle. And obviously this cramp is because of the coronary artery insufficiency. Later, this Anishkov, Nikolai Anishkov was a scientist in 1950s, just almost 75 years ago, told that no, it's, yeah, definitely it's because of the coronary artery disease. He actually proved on the post-mortem examination that it's because of the blockage of the coronary arteries or the obstruction or thrombus in the coronary artery. Okay, so in PM, they identified that the thrombus is in the coronary artery and they confirm on the post-mortem examination. Then in modern cardiology, Eugen Braunwald is there. Definitely, we all know about the book of the Braunwald's cardiology, right? So this is a modern father of the modern cardiology in the 20th century. And definitely he has done a lot of researches for the myocardial infarction. Coming to the coronary artery disease. So when we talk about the coronary artery disease, it is basically a coronary insufficiency. That means obstruction of the blood supply to the cardiac muscle, mainly associated with ischemia. All right. So this is about the coronary artery disease. Definitely, it has a huge spectrum under it. So one could be STEMI, that is ST elevation MI. Second is non-ST elevation MI. Third, angina. All right, angina itself is divided into the unstable angina, stable, and princemetal. All right. So what does unstable angina means? That means chest pain is always there. Chest pain is always there. What is stable angina means? That means chest pain is reproducible. Okay, reproducible in the sense is chest pain gets aggravated on certain factors. For example, walking. Okay, so this chest pain is reproducible on running or walking. And princemetal is nothing but it's a vasospastic angina where there is a vasospasm of the coronary arteries. You will also see some ST elevation changes for quite short time in these cases, and eventually it gets better. Okay, so this is about the different types of the coronary artery disease. Talking about the ischemic heart disease, again in the ischemic heart disease, all these things will come together. All right. Then cardiovascular disease is a blanket term. It will include ischemic heart disease, hypertension, all right, even cardiomyopathies, heart failure, valvular heart disease. Okay, all these things, even atherosclerosis, even any other vascular diseases will also come. For example, your peripheral artery diseases. Okay, peripheral disease. So all these things will come together on the term of the cardiovascular disease. Simple terms, just terminologies at the start. So now what we are using. So this is a huge definition that we are currently using. That is called as UDMI. That means universal definition of AMI. Okay. So heart, basically this MI definition was modified in 2018 and they give this big definition. So we really have to worry about this much definition? No. Basically, I have tried to simplify it for you. Just in this slide, you can see. Basically, they say, first of all, there should be an evidence for the myocardial injury, which will be obviously confirmed with the chest pain. That means which will present as a chest pain and patient will have ECG finding. All right. Second thing to diagnose or to label patient as a myocardial infarction was to have troponin that is more than 99th percentile. Okay, what does percentile means? Suppose this is the population, all right, and this is the troponin value. Let's say it's 0.012. All right. So more than 99th percentile, that means just 1 percentile of the patient has the troponin value of more than 0.012. Let's say it's 0.12. So it says that it is more than 99th percentile. Along with that, so this was just a graph that was telling that what is percentile. Now, along with that, they have added one more feature regarding the troponin in this 2028 definition. Okay. Troponin related in 2018 definition, they've added one more thing. Sorry, that there should be rise and fall of the troponin. If there is that rise and fall in the troponin levels, that means you have to subsequently check the troponin level of the patient. All right. So if there is a rise and fall, then only you can say this patient has a myocardial infarction. All right. Now, whenever you have a case of myocardial infarction, according to this classification, we have to classify. Okay, this is a classification of MI, which is important to know. First class is associated with the thrombus. Okay, so first class is associated with the thrombus in the coronary arteries, which is almost 90% common. Second is called as ICU-MI. All right, why ICU-MI? Because it is commonly seen in the ICU patients who are obviously having any other sources of infections. All right, so here patient has an oxygen and blood supply demand mismatch. Okay, so that is there. That's why it's called as ICU-MI. Then third is your ICU-MI. Okay, I'm just telling you, sorry, emergency MI, not ICU, EDMI. Okay, that means emergency duties or emergency room MI. Okay, why I'm saying that? Because here the patient will come into the cardiac arrest. All right, so patient will present in the cardiac arrest, and obviously on autopsy, we will confirm that it was nothing but the heart disease. Okay, or ischemic heart disease. Right. Then we have 4. So 4 is PTCA related. Okay, that means your angioplasty related, and 5th is your CABG related. Okay, CABG related. So depending on the duration, if it happens quickly, if it happens 0 to 1 year, or if it happens more than 1 year, it is again classified PTCA related. All right. So this is just a classification of the MI that you should know. So now when the patient has, first of all, evidence of myocardial injury is there. Second is troponin is high. Okay. And that is more than 99 percentile. And third is depending on the condition of the patient, you have to classify the MI. So that is nothing but the definition, that is UDMI, that is universal definition of MI. All right, let's see the classification quickly. We have already discussed this thing. Okay, so myocardial infarction due to coronary plaque rupture or erosion. Okay, so here occlusive or a non-occlusive thrombosis is there. Okay, so that thing you have to remember. In type 2, basically there is a demand supply mismatch, oxygen supply or demand mismatch. And here there is no evidence, without the evidence of the coronary plaque rupture. Okay, so whenever there is a evidence of the coronary plaque rupture, that is typically seen in the type 1 MI. Now you will ask me, how will you find that? So obviously we will have to do coronary angiography, right, for confirmation. If CAG shows finding positive finding, that means we are labeled as a type 1 MI. Type 3 MI, here patient will be coming in case of cardiac death. Okay, obviously cardiac death will be there, and on autopsy you have to confirm the finding. And in type 4, just after PCI, then second will be 4B, that is due to the stent or scaffold thrombosis, which will occur in 0 to 12 months. And then due to the stent restenosis, which typically occurs if duration is more than 12 months. Okay, even with the antiplatelets, if it's happening, then that's a type 4 MI. What we call as a recurrent MI. Earlier, we used to say it's a recurrent MI, but now you have different classes for the type 4 or type 5. And type 5 is your CABG related, coronary artery bypass grafting related. All right. So if you see the structure of the arteries, 1A, 1B, 1C, 1D. All right. So these are all 1. And we know when it comes to the 1, there is a coronary obstruction. So you can see there is a thrombus, there is a dissection of the coronary artery. Here again, there is a thrombus. Okay. And here there is a microvascular dysfunction causing vasospasm in that particular area, causing thrombotic or non-thrombotic type of obstruction. All right. Then comes type 2 MI. Now in type 2 MI, you will be saying that there is thrombus again over here. But there is a thrombus. And because of this thrombus, actually, atherosclerosis lesion, there is a supply-demand mismatch. And that's why patient is having symptom. Even you can see in type 2B, there is no thrombus at all. All right. So this is again the same type 1, where there is a plaque. Okay, there is a plaque. And if this plaque gets ruptured, and that will cause an embolus and cause complications. Okay. So similarly, over in case of type 2, you will have atherosclerosis that causing oxygen supply demand mismatch. Here you can see there is an intact lumen. All right. So this is how you classify type 1 and type 2. So what is myocardial injury? Again, what we discussed. So myocardial injury means, first of all, your complaints of the chest pain will be there. Okay. That means angina will be there. Second, very important, ECG findings will be there. Okay, ECG will reflect quickly within 30 minutes. ECG will show features. Okay, and your cardiac biomarkers. Okay, your cardiac markers basically should be positive to label the patient as a myocardial injury. All right. So here is the summary of the cardiac biomarkers. What we can say. So first of all, we know that CKMB is the first to rise and first to fall. Okay. Similarly, then we have troponin, okay, which rises quickly within 1 hour and again gets back within 4 hours. Okay. Then there is a troponin. Okay. And if there is no reperfusion, then it takes around 2 to 3 hours to go to the peak and then come back to the round. All right. So we prefer troponin nowadays. Okay. Even we have HS tropi, that is highly sensitive troponin, and that rises as quickly as the 30 minutes and gets back to the normal range within 90 to 120 minutes. All right. That is HS tropi, which is also used. Even HSCRP is there. Okay, that it can, but actually it's not very specific. Even just normal troponin is not very specific. All right. And initial phase, we used to use CKMB for confirmation because as you can see over here, It's getting to the baseline within 2 to 3 hours. So if there is a history or if there is a chance for the recurrent MI, that means the patient is having episode of the cardiac or chest pain, basically. And then we again used to do CKMB, and which used to show peak, and we used to confirm the diagnosis with the help of that. All right. So obviously, as I said, the cardiac, the troponin is not very specific. What are the other causes that when troponin will be high? So these are the some of the causes. So any cardiac condition, this myocardial perfusion is reduced in case of type 2 MI, what we discussed. Okay, like coronary artery spasm, embolism, coronary artery dissection. Dissection means if this is the tunica externa, media, and intima, if there is a break in the tunica intima of the vessel, and there is a blood getting stored into it, this is called as your coronary dissection, coronary artery dissection. Same applies with the aortic dissection. Okay. Then sustained bradyarrhythmias, hypertension, shock, respiratory failure, severe anemia. So here all in these cases, troponin will be elevated. Exactly, it can happen. Yeah, aortic dissection can happen. All right. Coming to these increased myocardial oxygen demand cases, like sustained tachyarrhythmias there, severe hypertension. All right, even other cardiac condition like heart failure, myocarditis, Takotsubo syndrome, coronary vascularization procedures. Okay, most importantly, you should know is defibrillation, shocks, and even post CPR. Okay, so what happens after defibrillation? You do, and you find that there is a elevated troponin. Even the ECG may show some features. Okay, because of the ventricular tachycardia or whatever the reason that you have defibrillated the patient. And now you do the tropa, it is positive, and then we all get confused that is it really MI or is what arrhythmia, or arrhythmia was due to MI. Then we start antiplatelet, again it starts to show other complications like stroke, etc. Okay, so yeah, you have to be sure that troponin is obviously not a sensitive marker. It can be increased in any other condition. And most importantly, you should know about the systemic conditions like sepsis, chronic kidney disease, even stroke like subarachnoid hemorrhage, pulmonary embolism, pulmonary hypertension, infiltrative diseases, chemotherapy, critically ill patients, and stomach exercise, and even myocarditis. Okay, even myocarditis. But what would be the classical feature to diagnose patient as a MI? First of all, it should be more than 99th percentile. And second, there should be rise and fall in the troponin. Okay, so rise and fall in the troponin. These are these classic features. Okay. All right. Coming to the approach to the chest pain. So I will explain it quickly to you. First of all, what are the typical features of the angina? Yes, can anybody tell me? Okay, I'll just write over here. Just tell me what is not the feature. Okay. First of all, chest pain on exertion. Okay. Then plus diaphoresis plus patient is having ECG changes plus patient is having good response to the nitrates. Okay. Or chest pain is getting relieved to the nitrates. So what is not among these three features over here is, tell me quickly. Which of these following is not the classical feature that you see in the typical angina? The ECG feature. All right. ECG is not necessarily to say that patient is having typical angina or not. All right. So only chest pain on exertion, diaphoresis, and nitrates. This feature should be there. Okay. So ECG is not necessary finding. ECG is a necessary finding to say it is a MI or not angina. All right. Angina is a clinical feature. All right. So then what is a typical angina? So any of these two patient has any of these two features and not the other feature, then it would be a typical angina, right? And then chronic stable angina, as we discussed, stable angina, that means symptoms are reproducibly precipitated. Okay. So this is the chart. Actually, all the charts I've taken here is from the Brown mold itself. And these are very important to know. First of all, we know angina, as we discussed, the chest pain will be there. And that chest pain is typically, burning type of heaviness, chest heaviness, etc. there. And that typically says that's an angina. Even rest or unstable angina, always there will be chest pain. but it is more severe. In acute myocardial infarction, it will be same as angina. And again, it is radiating to the neck, jaw, epigastrium, shoulders, left arm. So everywhere, basically, in the left side and even on the right side, it should get radiated. That's the feature of the angina. And that will be a heaviness or compression type of chest pain typically. Now, in case of CVS, there is one more condition, pericarditis. Here, sharp pleuritic type of pain, which will be aggravated by changes in position and by respiration. All right. All right. Then vascular. So vascular in the form of aortic dissection, pulmonary embolism, and pulmonary hypertension. So aortic dissection is the classical actually. I will tell you a story. So what happened when we were resident, we had a patient with a spine issue. All right. So actually this patient came with the back pain and his BP was high. Even his BP was 210 by 120. And I was in my first year residency. Okay. So obviously first year residency, we make a lot of mistakes, right? So I was first year resident. And what we thought was this patient was having high BP because of the back pain, because he has PIVD, that is prolapsed intervertebral multiple disc. All right. But when our professor actually came to the round, he actually noted that patient tells that there is a history of this ripping type of pain. All right. That means something is tearing at his back, and it is typically in between the two blades of the scapula. And that what it triggered. He thought that it's aortic dissection. We obviously did tropi. It was slightly elevated, but not that high, above the 99th percentile. And yes, we confirmed the finding by an investigation. So obviously, so it was the first year and so many things came together. But yeah, if you have the classical mindset of underlying to identify the underlying pathology, you can find any diagnosis. All right. So what is the investigation of choice for aortic dissection? No echo. Echo would be the first investigation, but that's not investigation. Exactly. CT aortogram is the investigation of choice. All right. CT aortogram. Again, pulmonary embolism. So we know it can cause sudden onset of dyspnea, pain, and mostly it's a pleuritic pain because of the pulmonary infarction. All right. Even pulmonary hypertension can cause substernal chest pressure, which is exacerbated by the exertion. Then pulmonary, in case of pleuritis, will be there, which will be varying with respiration. Tracheobronchitis, spontaneous pneumothorax can also have. Okay, in tracheobronchitis, you can have this burning discomfort in the midline, basically. And gastrointestinal is also there, where in case you will typically have retrosternal burning chest pain, which can be seen in peptic ulcer disease as well as reflux disease. Then gallbladder disease, pancreatitis also can have radiated chest pain. Finally, coming to the musculoskeletal, so here costochondritis, then cervical disc disease, trauma, etc. Even herpes zoster, okay, can have skin patches causing chest pain. Then psychological in the form of panic disorder. All right. So, which of the following is the most common cause of chest pain? GI, muscles, CVS, or pulmonary? Exactly. GI is the most common cause because the cases are more common. All right. So GI is the most common cause. Then comes is musculoskeletal, and then comes your cardiac cause. I have one more question for you. Quickly tell me. Patient comes to you with chest pain. Okay. I will try to draw a diagram. Okay. I'm not a very good at drawing. But let me draw. All right. So this is the patient we have. He started chest pain over here at this point. Then now chest pain is getting radiated to the right shoulder. That is number one. Chest pain is getting radiated to the left shoulder. That is number two. Okay. And now in number three, basically chest pain is radiating to the both. Okay. Both right and left shoulder. So in which condition you think that there is a highest likelihood ratio for MI? Okay. Which condition or which number you think has the highest likelihood ratio for MI? So you are saying that chest pain going to the left. Chest pain going to the left has the highest likelihood ratio. But I'm afraid to say you're wrong. Okay? Because they have studied in so many patients exactly that when chest pain is radiating to the right side, it has highest likelihood ratio. Then if chest pain is getting radiated to the right and left, it has second highest likelihood ratio. And if chest pain is getting radiated to the left side, then that has the least, or the, I would say third ranked likelihood ratio, right? So it goes like 1, then 3, and then 2, right? So that's what this chart is going to tell us. It is taken from the Brown wall. So a radiation to the right arm or the shoulder, highest likelihood ratio of 4.7. Radiation to the both arms and shoulders, 4.1. Radiation with associated with the exertion, 2.4. And radiation to the only left arm is 2.3%. But it's good that you at least think that whenever the chest pain is going to the left arm, there is an MI. But you should make sure that whenever chest pain is there, and even if it's radiating to the right shoulder, it's always an MI, and it has the highest likelihood ratio. All right. So this is the positive likelihood ratio. Similarly, we have negative likelihood ratio or reduced likelihood ratio for acute myocardial infarction. If the chest pain is pleuritic, that means varying with the respiration. If the chest pain is positional, that means there is a pericarditis. If there is a sharp pain, which can be seen in the musculoskeletal type of pain, reproducible with this palpation, again musculoskeletal, inframammary location. So here it can be related to the gastritis, etc., and not associated with exertion itself is a negative marker or negative likelihood ratio for the myocardial infarction. Right. Then comes what are the ECG features which has the highest likelihood ratio. So we know in definition of MI, we have ST elevation which is more than 1 mm, the highest likelihood ratio. Sorry. Just a second, guys. All right. So talking about the ECG, yes, in the definition also, we have ST elevation more than 1 mm has the highest likelihood ratio, even Q wave, ST segment elevation 11.2, new conduction defect 6.3, which we'll discuss when we discuss about the ECG features. All right, the only thing you should know is over here is ST elevation more than 1 mm has the highest likelihood ratio, and any conduction defect has the least type of likelihood ratio. So if you think that LBBB or RBBB has the highest likelihood ratio, then you're wrong. Okay, that because that has the least high likelihood ratio. All right. So this is the approach to the chest pain. All right. So whenever you have, I will simplify the table for you. Whenever you have chest pain, obviously first thing you will do is to do the ECG for this patient. Okay. First of all, history. In history, you have to rule out if it's, I will write from the number of causes, GI, musculoskeletal, cardiac, or pulmonary. Okay. In which system it is localized. Then ECG, we have to confirm that if it's STEMI or NSTEMI. Okay. Then third thing is you have to confirm if STEMI and NSTEMI is not there. Then you have to think about the D-dimer and CT-PA, basically rule out pulmonary embolism. And then if it's not there, then you have to do CT and autography. If patient's BP is high, rule out aortic dissection. All right. So this is the simplified approach for the chest pain that you should know. Obviously, ECG would play the most important role over to diagnose the MI. YouTube link I have already shared in the group, no? Let me check. Yeah, YouTube link has been shared over the message. Okay. It is shared over the message. Just check that once. All right. So this is the approach to the chest pain, and that's what it is written in this chart. All right. First of all, obtain 12-lead ECG, even X-ray they have said. Then ECG, if it's diagnostic of STEMI or if it's pericarditis, confirm with the findings of the ECG, which we're going to discuss when we discuss STEMI equivalence. Then confirm if it's pneumothorax, pneumonia, etc. Then check for the pulmonary embolism and then check for the aortic dissection. So this is the simplified approach for the chest pain, which is again taken from the brown ball. Coming to the core part now, that what is the blood supply of the heart and what are the ECG features which we see in different types of myocardial infarction. All right. So I will try to draw a simplified diagram of the heart so that you can remember it well. All right. So this is basically left side of the heart. Okay. This is basically left side of the heart. So this is how your right coronary artery will come. It will supply the SA node over here. It will supply the AV node over here and will come down like this. Okay. And this is your left coronary artery, left main coronary artery, which will give two branches. The first one is called as left anterior descending artery, like this. And the other one is called as left circumflex branch. Okay, LCX. All right. Exactly. Left circumflex. So this left circumflex supplies the lateral wall of the heart. Okay, lateral wall of the heart. LED supplies the anterior wall of the heart. All right. This right coronary artery supplies the right heart. Plus it supplies the SA node and AV node. And therefore, whenever there is a RCA or right wall MI, okay, whenever there is right wall MI, you can see bradycardia. Okay. There is a possibility of the bradycardia. Why? Because it is supplying SA node and AV node, which SA node is the pacemaker of the heart, AV node is the pace setter of the heart. All right. So this is the same. We have left main coronary artery, then right coronary artery, left main coronary artery. So left coronary artery gives branches, left anterior descending, which supplies the anterior wall of the heart, even anterior septum. Then there are some diagonal branches which will supply the anterior wall of the left ventricle. Coming to the left circumflex, which is a branch of the left main coronary artery, which supplies the lateral wall of the heart. Coming to the right coronary artery, it gives two branches, SA nodal, AV nodal branch, and the branch to the right ventricle. All right. So simplified, again, look over here. This is the left coronary artery. It is the left anterior descending artery. It is the left circumflex artery. This is the right coronary artery. Okay. So this is how the blood supply of the heart simplified for you all. All right. So now when we talk about the myocardial infarction, we should know how the lead placement is there, what is the axis, etc. Because the ECG features for particular area, okay, contiguous area that you should know. All right. So first of all, we know we have a precordial leads like this. V1, V2, V3, V4, V5, V6. That tells us about the horizontal section of the heart. All right. And then we have lead 1, 2, 3, even augmented leads, that is AVF, AVL, and AVF. So this will tell you about the vertical section of the heart. All right. So now, this is how the normal ECG, or you can say this is how the normal ECG axis is there. So first we have is your left side of the heart or lateral wall of the heart. So it is supplied by, or it is reflected in the ECG on the 1 AVL and this V5, V6, right? Because this is also located on the lateral part. So this is a lateral wall. All right. I hope you're understanding. Then talking about the V1, V2, look at this. They are close with the septum. All right. They are close with the septum. So V1, V2. And also you can see V1 is more over to the right side, isn't it? V1 is also more over to the right side. Even if you check at lead 3, all right, it is lead 3 is more toward the right side, isn't it? Than the left side, than lead 2. So whenever you have right ventricular MI, you will have ST elevation in V1 is possible, or even V1 can be isoelectric, and ST elevation in lead 3 will be more than lead 2. All right. That feature you have to remember for the right ventricular MI. Why I'm telling you? Because when we talk about the inferior wall of the heart, which is denoted by 2, 3 AVF, And why not V1, V2, V3, V4, V5, 6? Because these are horizontal plane. All right. So if you are understanding, this is the heart and this is one plane. This is checked by V1 to V6, that is precordial leads. And if this is the horizontal, this is vertical plane, that will be checked by your 1 AVF, sorry, 2, 3, and AVF. That will talk about the inferior wall of the heart. Now, one thing I forgot to tell you over there is, when right coronary artery supplies the right ventricle, it also supplies the inferior wall of the heart. Okay. So RCA also supplies the inferior wall of the heart. Therefore, in case of inferior wall MI, or if RCA is involved, there is a high possibility that RVMI can also occur. All right. And when it will occur? So, you know, in 2, 3 AVF, there should be ST elevation to call it as an inferior wall MI. All right. I hope you are understanding. In case of inferior wall MI, in 2, 3 AVF, there will be ST elevation, isn't it? When the ST elevation in inferior wall MI, ST elevation in inferior wall MI is more in lead 3 than lead 2, then you suspect that this is a right ventricular MI as well. So what you do, we just remove V4, V6, V6, V4, V5, V6 from the left side and place it on the right side. You can just remove V4 and you can place it on the right side. Just remove V4R and place it on the right side. And that's how you can confirm that right ventricular MI is there, which we will discuss. Okay, this voice breaking. I don't think. But anyways, when we discuss the ECG, I'm going to explain again. So don't worry at all. So right now we have discussed this much. Anterior wall V2 to V4, septal wall V1, V2, lateral wall 1 AVF, 1 AVL V5, V6, inferior wall 2, 3 AVF, posterior wall 1 to V4, sorry, V1 to V4, but this will be reciprocal changes. All right. We know V1 to V4 will display the anterior wall, but if you talk about the ST depression in V4 to V4, so that will be posterior wall. Okay, so that will be reciprocal changes. I hope this is clear. This much is clear. One just question for you now. We're going to discuss about the myocardial ischemia and how the ECG changes and why the ECG changes occurs. So first of all, there is a NSTEMI question about the NSTEMI, that unstable angina pectoris. Which of the following ECG findings are associated with the myocardial ischemia? ST segment depression, T wave flattening, peak T waves, U wave inversions, or none? Yes, anybody? Actually, it's none. All the features will be seen. All right. So all these features actually, ST segment depression, T wave flattening, peaked T waves, U wave inversion. Okay. Not in none, obviously. None would be the answer over here. But all these are features that you can see in the NSTEM. All right. So that's the answer over there. Other ECG patterns, definitely you can see is associated with the STEMI equivalent, which we're going to discuss in the coming discussions. STEMI equivalence. Okay, which we're going to discuss in the coming slides. So about the ST depression now, let's discuss quickly about the ST depression, because it is important to know that what is the criteria for the ST depression. All right. So first option is, so you have to identify what is wrong. First option is upsloping ST depression. It's highly specific for myocardial ischemia. All right. Just let's put a star over here. ST depression more than 2 mm in more than 3 leads indicates high probability of the NSTEMI. Okay, looks correct to me. Horizontal or downsloping ST depression more than 1 mm. At the J point, more than 2 contagious leads suggest myocardial ischemia. Okay, looks okay. And then ST depression more than 0.5 mm at the J point in more than 2 contiguous leads may indicate myocardial ischemia according to the 2007 task force criteria. So what we are talking about is ST depression right now. So I hope you don't know. So A would be the answer over here, because upsloping ST depression is not specific for myocardial ischemia. Okay, so remember, horizontal or downsloping ST depression more than 0.5 mm should be there. Then 2 contiguous leads should be at least show ST depression to confirm myocardial ischemia. Then ST depression more than 1 mm is more specific and conveys worse prognosis. And ST depression more than 2 mm in more than 3 leads suggests the high probability of the NSTEMI and myocardial ischemia. So this is how upsloping ST depression is there, which is not very specific for MI, myocardial ischemia. Then downsloping is there and horizontal is there, which are quite associated with the incidences of the myocardial infarction. I hope you got the point. So again, you can see over here, different ST morphologies are there. All right. So this is upsloping, this is downsloping, this is horizontal only. This is also a horizontal. This is also horizontal. This is also horizontal. I hope there is no doubt. Just remember that upsloping ST depression has it's not very specific. Coming to the T wave inversion now. So you can see T wave inversion in one area, isn't it? So how specific it is? So remember, T wave inversion can be considered as the evidence of the myocardial ischemia if it is at least 1 mm deep, present in more than 2 continuous leads, and have the dominant R wave, that is RS ratio more than 1. Okay. And if it is dynamic, not present on the old, that means it should be dynamic. That is, it should not be present on the old ECGs. Okay. And it should be changing over the time. Then only you have to think that it is because of the myocardial ischemia. All right. So 1 mm means one small box. I'll just zoom it a bit. So as you can see over here, it is 1 mm deep, almost 2 mm deep only over here. That means one small box is 1 mm, 2 mm. Okay. So this is 2 mm deep. Along with that, it has positive R wave. R to S ratio is obviously more than 1 over here. All right. And we don't know about the early ECGs, but yes, these are the criteria for the T wave inversion suggestive of myocardial ischemia. So widespread T wave inversion due to myocardial ischemia is the most prominent in the lateral leads in these patients. All right. Coming to the main topic, that is STEMI now. Okay. So I want you to answer the criteria on the STEMI over here. I hope you know, but yeah, quickly tell me which of the following criteria is not typically associated with STEMI. First of all, new ST elevation more than mm in 2 contiguous leads, correct? It should be there. ST elevation of more than 2 mm in V2, V3 in men, and above 40 years of age, okay, and over the 2.5 below the 40 years of age. It's also correct. ST elevation of more than 1.5 mm in lead V2, V3 in women. It is also correct. And ST elevation, if more than 1.5 mm in V2, V3, okay, it is wrong actually. Okay, so here in V2, V3, if the age is below 40 years, it should be more than 2 mm and it should be more than 2.5 mm. If the age is less than 40 years, that means it should be more than 2.5 mm. And if age is above 40 years, that means it should be more than 2 mm. Don't worry, we'll show you the criteria over here. Just a second. So this is the criteria for the ECG. I will simplify it for you. So ECG should have ST elevation, which should be more than 1 mm in 2 contiguous leads. Okay. Contiguous means the leads basically localizing to the particular area of the heart. So here we have 2 things that you should know. Talking about the male and then female. Okay. So then remember, age less than 40 years and age more than 40 years. All right. So it is applicable for all the leads except V2, V3. Okay, except V2 and V3. So what is the criteria for the V2 and V3 then? So in V2, V3, in case of male, if the age is less than 40 years, ST elevation should be more than 2.5 mm. And if age is less than, here it is age is more than 40 years, so it is more than 2 mm. Okay. Similarly, in case of female, it should be more than 1.5 mm and more than 1.5 for all the ages. Okay. So I hope you get what I'm trying to say over here, that for V2, V3, the criteria changes a bit because it is slightly closer to the chest wall. All right. So this is the criteria that you have to follow. Any doubts in this? So actually, that's what is written in this slide. Okay, ST elevation more than 1 mm in leads other than V2, V3, where the cutoff is more than 2 mm if the age is more than 40 years, and 2.5 mm if the age is less than 40 years. And for women, it is more than 1.5 mm. All right, so same thing I've just written in the flowchart form to make it little simple for you. Any doubts? All right, I hope it's clear. So these are the some of the features that will tell about the prior EMI. Okay, so what are the features of the prior EMI? First of all, Q waves will be seen in case of prior MI, and this Q wave will be more than 0.02 seconds. Okay, duration. Then Q wave will also can be more than 1 mm deep. Okay, and R wave will also be more than 0.04 seconds with more than R by S ratio more than 1. Okay, so these are some of the features for the prior myocardial infarction that you should know. Yeah, exactly. ST elevation means J point only. So see, this is P wave, this is the QRS complex, this is the T wave. Okay, so I will draw a J point थोड़ा अच्छे से. All right. So here is the J point basically. J point is nothing but a connection, not here also. All right. If this is how the wave is there. All right. This is basically a J point. This is basically a J point and it is elevated. That itself is called as ST elevation. Okay. So J point is a junction basically between the QRS and ST segment. All right. So with the help of this J point only, you tell that there is ST elevation or not ST elevation or there is ST depression. Okay. Coming to the important features, that what are the dynamic STD wave changes. So it's simple to remember. First of all, if this is how the ECG is, I'm not going to draw it. I'll rather stick to the image only so that it becomes easy for you to understand. This is how the normal ECG is there. First of all, changes will be hyperacute T waves. Then there is ST elevation. Then there is formation of the Q waves. Then there is a formation of the Q waves and inversion of the T wave. Gradually, as you can see, Q wave is still there. T wave is getting better. ST elevation is getting better. Okay, so this is how the dynamic STD wave changes occurs when you talk about ECG. So first of all, T wave is affected. ST segment will be get a gradually affected. Then Q waves. All right. Then your T waves get inverted, and then T wave get back to the normal, but Q wave stays like that. And in certain patients, as you can see, these Q waves get really deep to form QS complex. Okay, so this QS complex is nothing but a feature of the LV aneurysm. Okay, so because of myocardial infarction, there is an enlargement of the left ventricle causing this LV aneurysm. Okay, so this is a feature for the QS pattern. Basically, it can be a complication of myocardial infarction. A permanent ECG changes you can see in some patients. Okay, but if this gets reperfused in between during the occurrence of the T wave, ST segment, and even Q wave, this is how the ECG will look. All right. So if ECG gets reperfused, okay. So if ECG gets reperfused over here, you can see this in biphasic T wave inversion is there. That is typically seen in the pattern A of Wayland syndrome. Then this is deeply inverted T wave, which can be seen in the still it can be a biphasic only. As you can see, this is again biphasic. Here it is deeply inverted T wave, and here also inverted T wave. That will be a pattern B for the Wayland's. Okay, so this initially you will see biphasic, and gradually T waves will get inverted if reperfusion is occurring. Okay, so if reperfusion is occurring, your T waves initially will get biphasic like this, and then they'll get into the deeply inverted T wave. Okay, so this is about the dynamic ST T wave changes that you should know. Again, This is one more table that tells about the dynamic T wave ST changes. Here, initially T wave is affected, then ST segment is elevated, then Q wave is occurring, ST segment is elevated, gradually Q wave is there, inverted Q wave is there, and T wave is getting inverted, then Q wave is still inverted, and T wave is getting better. So this is again the same dynamic ST wave changes that you should know. All right, why it occurs? So obviously there are cellular, electrophysiological. So this different type of theories are there for why this temporal evolution occurs, which you can read. Not much important reasoning. Then coming to the 0 to 4. So what are the complications basically? So I've added complication here only because it is important to know. As you have just studied the temporal evolution phases, it will be easy for you to understand that what complication you can expect if you have myocardial infarction. So in all the phase, basically, you can have arrhythmia, heart failure in all the patients. Okay, even if it's acute or chronic MI, you can see all these complications at any point of time. There are few things that you should know over here that around day of 1 to 3, you can have fibrinous pericarditis. Then around the period of 2 weeks, you can have free wall rupture causing cardiac tamponade. Okay. So this is something you should remember because it has been asked in exams as well. And your professors are fond of asking this type of questions. Okay. So in the period of around 1 to 2 weeks, you can see this type of complication. Coming to the period or coming to the longer duration, more than 2 weeks to several months, you can have Dressler syndrome, etc., arrhythmias, aneurysm, and even dyskinesias. Okay, so these are the complications for the myocardial infarction. Coming to the ECG features now. All right. Just take a 1 minute break. We'll get back in 1 minute because ECG features are important. I don't want you to miss these features. Okay, just a minute. All right. Coming to the ECG features, very important. We have anterior wall MI, so that just you remember. Inferior wall MI, lateral wall MI, posterior wall MI. All right. Even right ventricular MI. All right. So these are the ECG samples which we're going to see. I hope you can understand and identify many of that. First of all, tell me what is the diagnosis in this ECG? Yeah, it's written over here. Easy to say. There is a ST elevation. As you can see, the J point is elevated in V2, V3. Okay, even V4. Look at this J point. It is elevated completely. So this will be anterior wall MI, isn't it? All right. So these are some of the features of the anterior wall MI that is written over there. Same. You can see ST elevation in V2, ST elevation V4, okay, even V3. Okay, even you can see ST elevation in 1 and ABL also is there, but it's not much. So it will be again anterior wall MI. Okay. Now tell me what is the diagnosis in this patient. You can see there is a deeply inverted Q wave with ST elevation. Here also there is ST elevation. Okay. Even in one ABL also you are seeing ST elevation, but there is some kind of strange wave in between. What is the strange wave in between? Yes, guys, quickly. What would be this? diagnosis. Okay, so this is a ventricular ectopic. Okay, this is a ventricular ectopic coming together with the ventricular response. So we have to say it as a bigeminy. That means ventricular bigeminy. Okay, so that is ventricular bigeminy with anterior wall MI. Now, can you tell me in this ECG what is happening? Look at this ST elevation in V1, V2, V3, even V5 how also has ST elevation, even V1, V6, 1 and AVL also having ST elevation. So again, this is anterior wall MI plus lateral wall MI. Okay. Tell me over here now. ST elevation in V4, ST elevation in V3, V2, even V5, even 1 and AVL. So again, this is the anterolateral MI. Same, this is a anterior wall MI. This type of wave is there. This is again a VPC. Okay, that is VPC. Again, this is a typical pattern. Can anybody tell me what is the name of this pattern? If you remember, this is tombstoning pattern. Okay, this is tombstoning pattern. Or look, it looks like a tombstone, right? Tombstone. So that is a tombstoning pattern that is typically seen in the anterior wall MI. And there's one more pattern like this. I want you to remember this pattern. This is called as shark fin pattern. And this is seen in inferior wall. Okay. So when we go in the inferior wall MI, I'm going to ask this again. So make sure you remember this. Okay. Coming to this sample ECG again, there is ST elevation, ST elevation, ST elevation, ST elevation. All right. Again, this is anterior wall MI. I've just added this ECG so that you are pretty confident on what type of ECG you are seeing. Coming to the inferior wall MI over here now. So again, this is a variant of the where the anterior wall MI is occurring. So look at this. If ST elevation in AVR is seen, okay, even ST elevation in V2 more than 2.5, V1 is more than 2.5 mm, and complete RBB pattern is there like this. So here also in V5 you can see that. So here obviously this is occlusion proximal to the S1 branch of LED. Okay, so segmental branches are there, S1, S2, S3, and if before that this type of features are there, then you have to say, but it's for the moreover to the cardiology people. For us, it's just an anterior wall MI. Nobody's gonna ask you that where is the lesion and all. Okay, but it would be good if you know that. Right. Coming to this ECG now, can anybody tell me? V2 shows ST elevation, V3 shows ST elevation, V5, V4, V5, even V6 shows, even AVL shows, 1 shows. Again, anterolateral. Okay, again, same, anterolateral MI. Coming to the lateral STEMI now. Look at this. ST elevation V6, ST elevation 1 and AVL. Okay, 1 AVL ST elevation is there. So it is a lateral MI. Okay. So high lateral STEMI. In high lateral STEMI, you will have ST elevation in V5, V6 and 1 AVL. Okay, so you can see over here. V5, V6 shows modest ST elevation, but 1 and AVL shows ST elevation with Q waves and T waves are inverted. That means what? It is a MI under evolution. हमने देखा ना अभी that in case of ECG, if you talk about the dynamic STD wave changes, you will have, first of all, tall T waves. Then there is the appearance of the ST segment elevation. All right. So I'm not drawn. I'll draw it like ECG so that you remember. So first of all, tall T waves. Then there is a ST segment elevation. Then there is the appearance of the Q waves. Then there is the inversion of the T waves. So here you can see there is an inversion of the Q and the T waves, isn't it? You can see this. So this is a evolved basically left or lateral MI. Okay, so this is an evolved lateral wall MI. Okay, so that will help you to make diagnosis myocardial infarction. Coming to the example number 3 over here, 1 shows ST elevation, AVL shows ST elevation, V5, V6, even V4, V2, V3. So again, this is the anterolateral MI. We have seen this ECG just before topic. Finally, coming to the inferior STEMI. So let's see inferior STEMI. So in case of inferior wall MI, you will always have ST elevation in 2-3 AVF. Okay, 2-3 AVF plus there will be some reciprocal changes you can see in the lateral ECGs. Okay, or AVL. AVL will show certain reciprocal changes. Okay, because this AVF and AVL are opposite to each other. Okay, so as you can see, sorry, this lead 3 and lead AVL goes opposite to each other little bit. Okay, so if you check about the AVF, okay, so ST elevation is there in AVF, ST elevation is there lead 3, and ST elevation is there in lead 2 almost. So this is basically a inferior wall MI. Okay, and you can see reciprocal changes in the AVL with the ST depression. Okay, so this looks like a mirror image to each other. See, AVL looks like just lead 3. Okay, now this is the pattern that is typical for the inferior wall MI. What is this called as? What is this pattern is called as? Yes, guys, quickly. I've just told you the name. Exactly, easy. Shark fin pattern. All right, shark fin pattern. Very good. Okay, and where do you see tombstone pattern? So this is your lead 2 showing ST elevation. Lead 3 also showing ST elevation. Lead 2, even AVF shows ST elevation. And rest of the AVL, look at this AVL. It is basically an opposite to this. Okay. Exactly. This is shark fin appearance. All right. So this is inferior wall MI. Now I've told you one thing, that whenever in inferior wall MI, ST elevation is more in lead 3 than lead 2. What you suspect of? Because lead 3 is more located to the right side, right? So this was the diagram. Lead 1, okay, lead 2, lead AVF, lead 3. All right. And this is your lead AVL. This is your AVF and this is your AVR. All right. So this lead 3 was located more over to the right side. So whenever you have ST elevation more in lead 3 than the lead 2, what does it depict? Right ventricular MI. Yes, correct. Okay. So this tells about the right ventricular MI. Now let's see if this ST elevation is more in the lead 2 or lead 3. So here, see, it is almost equivalent. Okay. It is almost equivalent. But this patient has severe bradycardia also. Bradycardia is there. All right. 1, 2, 3, 4, 5, 6, 7, 8. So 300 divided by almost 8. Okay. Right. So around 35, 36 type of rate is there. Okay. Coming to the right ventricular myocardial infarction now. So I will tell you when the ECG comes. So don't worry. So here, look at this ECG now. There is ST elevation in lead 3, lead 2, and lead AVF. Right. So all this has ST elevation. So anyone who has not seen this lecture will say that this is an inferior volume. But as you have seen, you know that if ST elevation in lead 3 is more than the ST elevation in lead 2, look at this. I hope you can appreciate this. ST elevation in lead 3 and lead 2. So obviously lead 3 ST elevation is more than lead 2. Plus there is a ST elevation in the V1. Look at this ST elevation in the V1. Isn't it? V1 is showing ST elevation. So even V2 shows ST elevation, modest ST elevation is there. So this is nothing but right ventricular MI. Okay, now you guys tell me what is diagnosis in this. So for the same patient, we just removed V4, which is placed on the left side, and put it on the right side. Okay, so let's see how the ECG is like that. So we remove V4 and we place it on the right side and we named it as V4R, and it is showing ST elevation now. So what does that tells? That definitely this is a right ventricular MI. isn't it? Are you getting it? Okay, so ST elevation in V4R is consistent with the right ventricular infarction. Let's see the example again. One more example is there. So here the ECG is actually not that good, but 2, this is lead 3. Lead 3 ST elevation is more than lead 2. Even V1 is isoelectric over here, but V2 is showing ST depression. Okay, so V1, even if it's isoelectric, so what is the criteria for the right ventricular MI? I will just write down the criteria for the right ventricular MI over here. First of all, there should be ST elevation in lead 3, which is more than lead 2. That is the first criteria. Second, ST elevation in V1 or ST flat, that is isoelectric ST segment in V1. And second, in talking about the lead V2 now, there should be ST elevation or even ST depression in V2. It doesn't matter for us. As far as V1 is showing isoelectric and V1 is showing ST elevation. Okay, so this is the criteria for the right ventricular MI. And obviously, it should be confirmed with the V4R. Okay, so V4R should show confirmation. So I hope you get what is the criteria now. So now I will show you the criteria. Okay, so the same thing what we discussed over here is V1 is the only standard ECG that looks towards the right ventricle, and lead 3 is a more rightward facing, and that's why it will show on the talk about the right ventricle. And this is how you place the right-sided ECG specifically. So V4R we have removed from here and we have placed it over here. Okay, so this is about the right ventricular MI, guys. Treatment we will discuss now. Finally, coming to the posterior wall MI. Finally, coming to the posterior wall MI. So see, I'll directly come to the ECG and tell you. Okay, so coming to the posterior wall MI, we know in case of posterior wall MI, your anterior leads, that is V1 to V4, should show ST depression. Okay, but remember one thing, this ST depression should be horizontal, not upsloping, downsloping, anything, just horizontal. So horizontal. So let's see. ST depression is horizontal, ST depression is horizontal, ST depression is slightly upsloping, but looks like moreover horizontal. You just have to look at V1, V2 only. So whenever you have this horizontal ST depression in V1, V2, V1, V2, you should go and do the posterior leads. So what do? We just remove V4, V5, V6 from left side, and we put it posteriorly in between the blades of the scapula. So if this is your spine and this is how the scapula is there, okay, this is obviously the man from back. Okay, this is how scapula is there. So we place V4, V5, and V6. Okay, that will talk about the posterior part of the heart. And obviously V4, V5, V6 will show ST elevation. Let's see now. Is it showing ST elevation? So see, V1, V2, V3 is showing ST depression, horizontal ST depression, and V4 that is now placed posteriorly called as V7, even V5, V6. So these are placed posteriorly called as V7, V8, V9. Yeah, look at this ST elevation in the posterior leads. So this is nothing posterior wall MI. All right. This is also one more example. Okay. In V1, there is nothing, but V2, there is showing ST depression, which is horizontal. Okay. Even V3 is showing ST depression, which is horizontal. Okay. And on checking on V7, V8, V9, sorry. On checking V7, V8, V9, you can see there is a ST elevation. Okay. There is ST elevation. So one striking feature I want to tell you over here is when we check on the V7, V8, V9, which are what? Posterior leads, isn't it? These are posterior leads. So in this case, even ST elevation of more than 0.5 mm can be diagnostic for MI. Okay. So that's about the posterior wall MI. Is it helping, guys? Are we going too fast? Do you understand? Similarly, V1 shows no change, but V2 is showing ST depression, which is horizontal. V3 is showing ST depression. And when we do the posterior leads to this patient, let's do the posterior leads. Have they done? Yeah, we have done. There is ST elevation in the posterior leads. Okay. So this is again a posterior wall MI. These are the posterior leads before V6. Okay. So you can see ST elevation is there. So ST elevation even more than 0.5 mm can help you to diagnose myocardial infarction in the posterior leads. So actually these are the B7, B8, B9. Okay, which is showing ST elevation. I hope you get. Here also you can see ST depression in V2, V3, V1. Check on the posterior leads now. See V7, V8, V9. Okay, I don't see V9, but yeah, V7, V8 they have done, and there is ST elevation. So this is again a posterior wall MI. I hope you're getting. So we are done now with the stemming. That is ST elevation MI. All right. So where we saw different types, like anterior wall MI was there, anteroseptal MI was there. Septal means V1, V2 to V4 if there is a ST elevation. That is called as anteroseptal. Then anterolateral MI is there. Then high lateral MI is there. Okay, high lateral or lateral wall MI. Then inferior wall MI. Then right ventricular MI and posterior wall MI. Okay, so we saw this many ECGs till now. So this will be included into the STEMI equivalent. Why? Sorry, not STEMI equivalent. These are STEMI only. That is, there is a ST elevation in this patient. But in certain ECGs, even if there is no ST elevation, it's not there. But still, you will call it as a STEMI equivalent. That means ST elevation MI equivalent. Why? Because these are also deadly. Because these are deadly and has to be treated like a STEMI only. Okay, so this has to be treated like a STEMI only. So in which condition this will happen? So first of all, we see posterior wall MI. All right. So we discuss posterior wall MI in the STEMI itself, but it is actually a STEMI equivalent because in V1, V2, there was a ST depression. Right. So even was ST depression is there. We treated this patient as a STEMI. All right. So that is your posterior wall MI. Second is D Winters T wave. D Winters T wave. So what happened in D Winters T wave? In precordial leads. In precordial leads, basically, there is a upsloping ST depression. Okay, so like this is P wave, this is QRS, and this is how the ST depression goes and ends up in the T wave. This is called as upsloping ST depression ending up into the T wave, which is tall. So this is a classic feature of the LED stenosis, proximal LED stenosis. Proximal LED stenosis. Why it occurs, when it occurs, we don't know. This is a pattern that you should know. Okay. So talking about the D Winters T wave, this is how it will look. Then coming to the Wellen syndrome. So Wellen syndrome, I hope you know now. I just recently made a reel on that. So in Wellen syndrome, when we talk about the reperfusion, so this is a typical ECG pattern. Okay, typical ECG pattern where whenever there is a chest pain, ECG might appear normal. Okay, and if there is a no chest pain, then ECG might show two patterns. So first of all, this is P wave, this is QRS. Okay, this is your T wave. Okay, this is biphasic T wave, isn't it? This is biphasic T wave. Why? Because there are two phases in the T wave over here. This is biphasic T wave, and it is called as Wellens type A, which we also saw when we were discussing about the STD dynamic changes and the reperfusion. Similarly, if this is a P wave, this is a QRS complex, and this is how the T wave occurs. So this is called as valence type B. Okay, valence type B. So this is a deeply inverted T wave. Deeply inverted T wave. All right. So now why ECG appears normal if there is a pattern like this? So as we know that there is already T wave inversion. Let me draw it over here again. Okay, so we have ST depression like this, isn't it? So T wave inversion like this. So what happens in chest pain? Normally there is a ST elevation. But in this patient, already you can see the T wave is already inverted. This T wave goes up and appears as a pseudo normalization. This appears as a pseudo normalization, and that is a your Wayland syndrome, okay, where ECG looks normal if chest pain is there, and this is a deadly disease associated with the LOD stenosis. Okay, and definitely treatment includes PCI. Okay, right. Along with that, hyperacute T wave is also a STEMI equivalent, right? Because in STT dynamic changes we saw, the first thing to appear was hyperdynamic T wave. Many people may get confused with the hyperkalemia. So this is the chart now that talks about the, and one more thing left actually, that is 5, is associated with the left bundle branch block or LV pacing. So if you have, suppose this is the ECG, okay, I will show it in the diagram only. Okay, so these are the, first of all, these 5 are the STEMI equivalent that you should know, which are summarized here in this chart. So first of all, conventional STEMI, which looks like this, then De Winter's T wave. Okay, if you remember the pattern, De Winter's T wave, I said it's a upsloping ST depression. Then posterior STEMI, here we already discussed there will be ST depression in V1, V2, and still it will be treated as STEMI. Coming to the valence sign A, here look at this biphasic ST depression, biphasic T wave inversion, sorry. In valence type B, there is a deeply inverted T wave, hyperacute T wave is there. Scarboza criteria, Scarboza criteria, Scarboza criteria. This is for the left bundle branch block and LV pacing, okay, which we're going to discuss in the coming slides. All right, so this is again same for the Wayland syndrome. These are the sample ECGs for the Wayland syndrome, which you can go through. Okay, I will just show you one sample. So look at this. Patient is experiencing chest pain and diaphoresis, and there is a subtle ST elevation in V2, V3 in the initial phase. Okay, gradually there is a resolution of the pain and a reperfusion is occurring. Okay, so resolution of the pain and reperfusion is occurring, which is showing this biphasic T wave inversion. Okay, biphasic T wave inversion, which goes with the valence sign A, valence A pattern. Here, gradually ECG starts looking normal. Okay, and as the ischemia ongoes forward, ST elevation becomes again prominent. Gradually, as the symptoms improve and patient's coronary reperfusion occurs, ECG starts looking normal again. And when now there is no chest pain. Try again. When there is no chest pain now, there's a ECG is appearing like this, which is completely reperfused. And here we can see this is appearing little biphasic in the initial phase. Okay, so this is how your Wayland's syndrome goes. Okay, so just make sure that whenever there is a chest pain, all right, and if you're seeing this type of pattern, you have to be worried about the Wayland's syndrome because it has high mortality as well. Now coming to the Scarboza criteria, which is typically seen in the left bundle branch block patients. So we know about that formula, William and Marrow, isn't it? So WM, the MW, V1, V6. So in case of left bundle branch block, your V1 will show W pattern. In case of right bundle branch block, marrow RR comes, right? So it will have V1, which looks like a M. Okay. So depending on that, we have for LBBB, basically, we have a criteria that is called as Scarboza criteria. Okay. So remember this Scarboza criteria now. It's very easy to understand. So according to the recent guidelines, if the score is more than 1 point, it is a diagnostic for the myocardial infarction. All right. But what is the score and what type of score is there? First of all, this is ST elevation. All right. And QRS is in positive direction. All right. So as you can see, this is the R wave. It is in the positive direction. ST segment elevation is there. So this will be called as concordant ST elevation. Okay. What this will be called as concordant ST elevation is there. Similarly, when we talk about this part, your QR segment is negative over here, but ST segment is elevated. So this will be called as discordant ST elevation. I hope you are understanding. And similarly here, your QRS is negative, ST segment is depressed. That will be called as concordant ST depression. Okay. So earlier, they used to give different score for different this type of morphology. But now one score is given for all of them. And if in any ECG pattern, basically, you have this type of pattern that will be labeled as a. So if you have this pattern in ECG at any point and the score is more than 1, that will be labeled as a myocardial infarction in patients of left bundle branch block. So I will show you an few examples now. Here you can see in one AVL, you are having ST, your QRS is, look at this, QRS is positive, R is positive, and patient is having ST elevation. So that will be labeled as 1 point. Okay, and that is typically seen in patients of left bundle branch block. Look at this left bundle branch block. This patient is having left bundle branch block, and your score is more than 1. That labels this patient as the myocardial infarction. We have one more example over here. Here also you can see there is a R wave negative and ST segment is also negative. This is your concordant ST depression. Okay, this is concordant ST depression, labeling this patient as a myocardial infarction in this patient. Okay. All right, great. Final part of the discussion of the today's topic. After that, we have a treatment. So what are the other STEMI equivalent, which are actually not, it's like, which mimic as a STEMI? I would say not STEMI equivalent, but these are STEMI mimics. So one is acute pericarditis and the other one is benign early repolarization. So I will just tell you important features about that. So acute pericarditis will have this type of concave ST segment elevation. Concave ST segment elevation. Whereas in case of MI, you will have convex ST elevation. Okay, convex ST elevation is there. Now talking about the benign early repolarization, it is seen in the normally, it is a normal phenomena, can be seen in young patient, okay, can be physiological. And here the J point is at the normal point, but it mimics like ST elevation. All right. As such, there is no ST elevation. The J point is slightly elevated, but it is not ST elevation. So obviously, in case of pericarditis, there are no reciprocal changes. No reciprocal changes. Okay. Similarly, in case of BER, that is benign early repolarization, there are no reciprocal changes. Okay. Only in case of MI, if you have anterior wall MI, you can see posterior. If you have posterior, you can see anteriorly. And if you have inferior wall MI, you can see laterally. Okay. So anterior, posterior are reciprocal. Posterior, anterior are reciprocal. And if you have inferior, then lateral. Okay. So this is how are the reciprocal changes in case of myocardial infarctions. All right. Same way, obliquely straight, can suggestive STEMI. Concave, here also you can see, typically is in non-STEMI, and non-concave or convex is typical for the STEMI. That's it about the myocardial infarction, guys. I hope you liked the session. In a nutshell, we tried to cover all about the MI. And let's see if we can continue with the treatment part. Okay. Okay. So I have one chart for you so that you will understand the treatment in a nutshell. Table. Actually, it might have got deleted. But yeah, I will just tell you over here in a simplified way, because I know most of us have the idea about the treatment of the STEMI, and you can also read that. But I will just simplify it for you. Whenever you have a STEMI, all right, first of all, we look for the what is door to balloon time in this patient. All right. So that means in how much time you can do the procedure. So if PCI is available within 120 minutes, PCI is per coronary intervention, percutaneous intervention for the coronary arteries. So here, if it is available within 120 minutes, then we go with the PCI. Okay. And the target time should be within 90 minutes. Okay. That is the target goal for that. And if the time required to shift the patient to the PCI capable hospital is more than 120 minutes, then we should do thrombolysis. Okay. So PCI is obviously done by the cardiologist. Okay. And for this thrombolysis also, we have a golden period. For golden period or golden time, we have is within 60 minutes, we should do. Okay. We should do within 60 minutes. Okay. So this is the simple, basically chart you should follow when we talk about the treatment of the myocardial infarction. I will just go to the important drugs that you have for the thrombolysis. So we have alteplase, tenecteplase, retiplase, streptokinase. So these are all recombinant tissue plasminogen activator, which basically break down the clot by inhibiting. I will share it, no problem. It is actually at the bottom of the table or bottom of the notes. Okay, but no problem. I'll share it again. Okay, so here we have streptokinase. So tenecteplase we use most of the time because it's available as a single IV bolus. Okay, alteplase, it is most clot specific. Okay, it is most clot specific. Tenecteplase is most preferred because it's a single bolus. Okay, and how do we give this? So alteplase is given as 0.75 mg per kg over a period of 30 minutes. All right. So overall 90 minutes total we have to give after bolus. So first bolus 15 mg, then over a period of 30 minutes you can give infusion. And tenecteplase, if age is less than 60 kilograms, you have to give 30, 60 to 70, 35, 70 to 80, 40, 40 to 90, sorry, 80 to 90, 45. All right. And more than 90, 50. So maximum dose we have to give is 50 mg of tenecteplase. Remember, it has to be given over a period of 5 to 10 seconds. Finally, retiplase and streptokinase. So this is retiplase, this is 2 bolus, and streptokinase as a single infusion over the period of 60 minutes. So what are the relative contraindication or absolute contraindication? These are important that you should know. Absolute contraindication include any history of ICH in the past or any stroke of unknown origin. Okay. Then ischemic stroke within last 3 months. Then intracranial neoplasm or AV malformation or any aneurysm in the brain. Okay. Then active bleeding or bleeding diathesis like peptic ulcer disease exceeding the menses. Obviously, menstrual cycle is not a contraindication. Okay. Menstrual bleeding is not a contraindication. It's a relative contraindication. Then significant closed head or facial trauma within last 3 months. Suspected aortic dissection. Recent intracranial or intraspinal surgery. Then severe uncontrolled hypertension, that is BP more than 180 by 110, and known structural cerebral vascularization. Okay, so these are absolute contraindication. What are relative contraindication? So history of chronic, severe, poorly controlled hypertension. Okay, so poorly controlled hypertension is the relative contraindication. Please remember, But if BP is more than 180 by 110, that is an absolute contraindication. Then dementia is a contraindication. Traumatic is like not included in the absolute contraindication, obviously. Traumatic or prolonged CPR is a relative contraindication. Major surgery within 3 weeks is a relative contraindication. Recent internal bleeding within 2 to 4 weeks, non-compressive vascular punctures, pregnancy, very important, very important, very important. You should know this has been asked several times that it is a relative contraindication, not the absolute contraindication. Then active peptic ulcer disease and current use of anticoagulant. Okay. So when we talk about the bleeding diathesis, remember active peptic ulcer disease is a relative contraindication, which I have mistakenly added over there, but it's a relative contraindication, right? And other bleeding diathesis like esophageal varices, etc. Okay, active bleeding because of that. That could be an absolute contraindication for fibrinolytic therapy. All right, that's it, guys. That's it for this session. I hope we discuss MI in detail. From basic to advanced, we cover the ECGs, and we did not talk about the treatment much, but the treatment of the MI is this much. Plus, you should know how to manage the acute decompensated heart failure, which we will try to take in the next session. Okay, so ADHF is very important. So if you like the lecture, please share this with your friends for MI preparation. Okay, and obviously you can ask your friends to get the course, and if you like it, please share this with your friends as well. Yes. Okay, I will share the notes. Okay, then and then only, no problem. Okay. So I hope you liked the lecture. Was it good today? All right, let me know in the comments on YouTube, and I will make it live. This lecture, I'll make it available for the others as well on YouTube, so that it will help them to study as well, because it is an important topic. And let's see, if you guys are interested, I will add the link in the comment section of this video. Please subscribe to this channel on my YouTube, basically. That's Dr. VG Medicine. Thank you so much. Bye-bye. Take care.